Hi, everyone. Welcome to episode 3 of our virtual reality focused podcast. My name is Mike Brock. I'm a product manager and the education lead at PrecisionOS. And Danny, would you like to introduce yourself?
Hi, Mike. My name's Danny Goyle. I'm an orthopedic surgeon as well as CEO and one of the founders of PrecisionOS. It's nice to be here again, Mike.
It's nice to have you. So,
Hmm.
topic of conversation today is going to be focused on anatomy.
Great.
So, one of the key principles, the pillars in surgical and medical education is understanding anatomy of the human body, how things are situated within the body, tips and tricks on how best to learn it, what technology can really do to sort of advance your training and education. But
Right.
why don't we kick off there? Why don't we kick off with some of the concepts around anatomy that foundationally you expect a resident to come into your OR with understanding?
It, it's a really important topic. And it all goes back to when we think of medical school, it's one of the salient points and rites of passage is to go into the cadaver lab as a medical student and dissect and understand your anatomy and do the bell ringer exam. And things have changed quite a bit. And if we look at medical schools across the world, some of them don't have access to cadavers, and those that had ample supply, there's this sort of declining access to cadavers. And I'll share a quick statistics on cadaver supply. It's actually, according to the Cremation Association of North America, this is published on their website. They expect the cremation incidence to go up to almost 80% by 2035 or 2040. And cremation precludes patients from being used in cadaver labs because that has to be done usually in close proximity to death. But going back to your question is, how do we teach people foundational anatomy with the expectation that if they come to the operating room, they have a deep sense of that three-dimensional orientation of where the nerves are, where the vessels are relative to the muscles and different planes. It's a really complex thing, and we've been learning anatomy outside of the cadaver lab, mostly using apps in 2D. What about you, Mike? I mean, you've done some teaching in the medical schools
Yep.
in London. What's been your experience there?
So I mean, I'm gonna frame it by beginning as the learner, the perspective of the learner.
Right,
And anatomy for me, predominantly in undergrad, was memorization. So you'd have a textbook,
right.
you'd have structures, they'd be labeled, you'd memorize the order that they appear in, from top to bottom. And in changing over now to being an educator in a 3D environment, just doesn't fly. Like if you look at the brachial plexus, yeah, you can understand how it looks as a 2D plane, but once you get in there and you see a 3D structure and nerves are going every which way, and you still need to know which ones they are from a different
Oh, yeah.
perspective. If you're coming posterior, anteriorly, superiorly, it's a whole different ballgame. And so I
Yeah,
think what used to jump off the page to me and I could memorize in a night of studying
yeah,
is totally different when you think about it in a context that's usable. Because that rote memorization of being able to regurgitate all the acronyms and
yeah.
memorization sort of ways of going through getting those structures in order just doesn't work when you're talking about it in a surgical context.
I agree. And even beyond surgery, this is a foundational knowledge for every single person who has interaction with a patient, whether you're a paramedic in the field, a nurse on the floor, a medical student, an anesthesiologist. It doesn't matter. I mean, anatomy is so foundational for all of us who talk and treat patients. And and I think if we focus our energy on learning and optimizing that learning, we're actually going to be able to change fundamentally how healthcare is delivered. So that foundational knowledge is the pillar of medicine globally. And when I say medicine, I'm including all healthcare and allied healthcare providers.
Yeah. I can remember you were talking about cadavers. They would roll out sections of a
Yeah.
cadaver into our anatomy lab where we would look at structures that were preserved for what felt like 3 years,
Hmm.
that looked nothing like human tissue at that
Yeah.
point. And
Yeah.
they'd have pins in them and they'd try to get us to understand what's what. And connecting the dots between what was on that textbook that I was
Yeah.
reading from and what I was looking at that cadaver was kind of, it felt like guesswork because part of the problem was things didn't look the same. When you have
Right.
a lovely textbook and things are highlighted for you and it's all spelt out for you in a clear and digestible way
Yeah.
versus a cadaver whose tissues all sort of meld together, you start to really question, am I really learning this in the way that I should be? Because if I'm supposed to connect the dot between these two things, I'm not. And I think it's a mixture of that sort of 2D to 3D spatial reasoning,
Yeah.
as well as the structures themselves that don't look as they do on textbook. And having some happy intermediary is something that I think would be valuable.
And cadavers are extremely valuable. And one of the things I'll comment on is when you look at the studies on the value of cadavers, the greatest benefit actually comes from a fresh cadaver, which means you use it within 24 to 48 hours, somewhere along that timeline, immediately after the deceased. That timeline is really impossible to meet. And so this is why the deterioration of the cadaver occurs, because we have to store it, et cetera. But if we move beyond that for a minute and then talk about skill transfer, I remember vividly I was in a lab teaching another surgeon about shoulder arthroscopy portals. And one of the things that we had to do is, because the cadaver was quite thawed and quite decomposed at the time, is the humeral head was sitting very low in the glenoid. And so he made his portal quite a bit lower on the lateral part of the shoulder. And what occurred to me is I had to correct him, and I just stopped him and said, this is not the correct place to put the portal, because you're now working around the axillary nerve. And if you damage that, then you'll have a dysfunctional deltoid. But I don't know if that's what he thought until I mentioned it. And the reason he made that portal so low is, if this is the glenoid and the humeral head sitting over here, and you're trying to get on top of the humeral head, or actually in the joint, you can see how low your portal has to go. I'll just move my hand up. And so there was a significant fear in my mind that I'm teaching this person and transferring negative skill onto him when he goes into the operating room to do an arthroscopic procedure, which actually scared me quite a bit, because I had not thought of that before. Because you always think of cadavers being the gold standard, but
Sure.
that to me, and we don't know how often that's happening, where the anatomy is malpositioned and negative skill transfer is happening. But that was interesting for me to see and experience.
I, another anecdote that was you and I sharing some time in VR that really sort of opened my eyes to this exact problem of sort of
Hmm.
3D spatial understanding
Right.
is you mentioned to me that the glenoid and the scapula itself sort of sits 30 degrees anteriorly sort of
Yeah.
focused from the patient. And
Hmm.
so until I'm looking at that in a 3D setting, if I'm reading it off of a textbook, every textbook has glenoid humeral head right side by side in a perfect
Hmm.
sort
Right.
of crescent moon
Yeah.
and the shape of it. So you kind of assume instinctively that yeah, that's the angle. It just comes straight off the shoulder, perpendicular, and it really
Yeah.
doesn't. But once you can see that in a 3D setting, so you and I went into VR together, and I'll show the clip while I'm talking about this.
Right.
It jumps off a page. You start understanding that things aren't as clear as a 2D flat planar surface, that everything's going to work perpendicularly, and understanding the relationship between those structures really helps in a 3D environment.
And it matches our way to learn, because if we're aligning 3D activity or 3D expectations with 3D education, we've now matched the two. But if you're asking a student to translate in 2D, create a mental model of 3D in their brain, and then bring it into life in the real world, that's where the challenge is. And I think that's where things like memory come into play, because now you're just memorizing this nerve innervates this muscle and this blood vessel travels between these two planes. So it's a very interesting concept, and something that I think needs to be addressed for us to, as mentioned, change how healthcare providers learn anatomy.
Yeah, I think that's really well said.
Yeah,
There's another topic we want to talk about today,
sure.
and that's the tools that software has available to it in this day and age that can really help with these sort of concepts of understanding what's what and where it is,
Right,
how it exists.
right.
And one of the coolest things that we've developed recently is an AI model that can
Yeah,
actually have a conversation with a participant in the virtual setting to discuss these exact things. So, would love your take on this.
yeah, yeah,
Say it was way back when and you were
yeah,
prepping as a resident for surgery. What kinds of things would you find yourself looking for in a textbook at night or on the web to sort of try to answer that you think this might
yeah.
help to sort of fill a gap?
So if I was preparing for a case, and we use a shoulder as an example, I really want to know where the nerves are, because that's the thing that worries me the most, is where are the nerves that I could injure, and where are the blood vessels that you could injure and a patient could bleed. Knowing the spatial orientation of those nerves and vessels relative to where my retractors are and where the muscular planes are going to be is the most critical point because that's the thing that keeps us worried when we're in the operating room. As a shoulder surgeon, I always know where the axillary nerve is. In fact, I can palpate it with my finger. I pause, it gives me relief when I can feel it and I know where it is. And that's a skill that I learned as a trainee as well as a fellow. And then now I do as an attending. But, going back to the point of, spatial understanding and when I'm learning about approach, those are the kind of things I want to know. But there's no good one resource that I can find those in. The second thing I want to do is I want to be able to ask somebody some really silly questions and not be judged about it. And I mean, no one likes to ask, silly questions, and people say there's no such stupid question, but stupid is in the eye of the asker, I would say. It's the person who's asking who doesn't feel that this is a very good question. So having that safe place to ask somebody a question would be what I'd be looking for in preparation of a case.
Yeah, we've all been there before.
Yeah,
I've many times I've had questions I would love to know the answer to, but I'm afraid to ask because
yeah,
it might be so novice that it's
yeah,
just it paints me in a bad light.
sure.
But being able to
Yeah,
have that sort of open discussion of, can you show me where the axillary nerve is, and
yeah,
potentially to the point of being able to pull it out and seeing it as a 3D structure on its own, or
yeah,
toggling other layers of anatomy off to really sort of make it a clear explanation and delve
right.
down into the basics of it, right? So
Yeah,
in Bodyworks right now,
yeah,
we have this Delphi AI software that is a
right.
conversational AI that you could legitimately ask, show me the axillary nerve and turn off all the musculature and
Yeah,
associated ligaments that are nearby so that I can see it really clearly. And it will actively do that for you. So it's
yeah,
these tools of being able to both visualize these structures in 3D and ask the potentially stupid questions you don't want to ask someone who might judge you for.
right.
Seems like a win to me.
Yeah, this is a really interesting application that we've developed, Mike. And as you know, it's in beta, so it's early days for this. But you could actually instruct it to ask you questions based on your level. So if you say, I'm a student nurse, a paramedic, a medical student, or a surgeon in practice, it will it will actually cater the complexity of questions to your level of training. The other thing it'll do is it can actually ask you questions, which is really interesting because we always think of asking a mentor questions, but there's value in being asked a question as well, because it actually is a deeper assessment of your knowledge of a topic if you can answer a question as opposed to just ask the question yourself. And so having this dialogue, this conversational interaction with this AI mentor, which as you mentioned is named Delphi, is, a really powerful thing. And the feedback we've had so far has been really positive.
I think what's hard to grasp until you
Yeah,
actually experience it is it's not only an AI chatbot that is
right.
controlled via voice, but there's also that full virtual patient that is
That's
there and
right.
it controls. And
Yeah,
that's what really sets it apart. It's not just you typing out to ChatGPT,
that's right.
give me all the nerves. It's literally trying to show you in
Yeah,
a controlled environment the exact things you're trying to see in the moment. So it's both the mentor and the visualization coach all in one.
it's an excellent point. Auditory and visual feedback all in one from your mentor. You're right. If you say, I want you to zoom into the shoulder, and all of a sudden the shoulder's 3 or 5 times the size it was before, and then you turn off all the different muscles to show you a particular nerve or a blood vessel, you're right. I mean, it's absolutely a different way to think about learning and teaching.
Yeah. Now, to build on this, I think we should be clear on what the software currently can do and what it can't.
Yeah, yeah,
So I think sometimes expectation precedes what technology can really do.
right.
And we've built a lot into these applications we've been making, and we always want to keep building more, but it doesn't replace the cadaver. And I think that's how we started this conversation.
That's right.
Cadavers are valuable. Like it is so intricate and so detailed that in the current day and age with the technology at our disposal, there's just not enough horsepower to really recreate a cadaver
Yeah,
one to one.
that's right.
But what it does do a really good job of is making that anatomy textbook jump off the page and present itself in 3D with additional visualization controls at your disposal. So I think
Yeah.
that's really a good way to think of it. It's not a replacement for a cadaver, but it certainly supplements and will give someone a jump start. to getting more comfortable with that problem I had of I'm looking at a cadaver and all this tissue is just melding together, and what I assumed was the subscap is not because I
Yeah.
can't tell the difference.
I think the other point that it highlights, Mike, is we're not trying to replace a cadaver, but what if you could still have access to a cadaver, but then do and have access to a three-dimensional virtual cadaver at your disposal whenever you want on demand? And I think it really empowers the learning for the student. And this concept called spacing effect is a very well-known educational approach to retaining knowledge. If you describe the forgetting curve, which is very well described by Hermann Ebbinghaus, if you learn something today but you don't apply it for 7 days, you'll lose 70% of that knowledge. It's the most sustained evidence of how we learn to date. I think it was published in something like 1885. But the way to mitigate against that is if you can do micro learnings throughout your education until you get to that time where you're going to have to apply that knowledge. And that spacing effect is where this really sort of hits home. The other thing is it's affordable, meaning, cadaver labs, simulation centers, again, although we're not trying to replace it, what about the areas in the world that just don't have access to that type of three-dimensional learning? What do they do? And so when we think about democratization of anatomy education, there has to be a different way. And I think this helps us build the bridge towards it.
I think that's a great way to position it. And also a lovely segue into us sort of wrapping up this conversation on anatomy.
Fantastic.
What do you think we should talk about next time?
Well, I think we should really dig into the next phase of where we're going with this technology, Mike, and that's personalized learning. When I think of, and I'm sure you have the same experience, I've sat in a classroom with 800 students, and we all heard the same topic. What we retained and how we learned this was individualized for each of those 800 people. Where we're going with this technology is if I can personalize the experience for every single user of this technology and provide performance insights, competency insights into their learning, that's where we're going next. And I think that would be a really great topic of our next meeting.
Personalized learning and implementing it into our platform. Sounds like a great topic. And that's what we'll talk about next time.
Awesome, Mike.
So thanks everyone for listening, and until next time.
Thank you. Good night.
Bye.